Okay, we're going to go ahead and get started. And this is a recording of chapter 1 in the Hart and Rollins book. The chapter theme is separation and coping. As an introduction, a children's understanding of illness, it varies by age, cognitive ability, and level of knowledge. From 2 to 7 years, they perceive illness to be caused by external factors or magic or, make-believe. 7 to 10 years of age, they perceive illness to be caused by a person, an object, or an action. In other words, sneezing without covering your mouth, that sort of thing. Coughing in public. 13 plus years, they perceive illness as a malfunctioning process of the body. They have a little bit more concrete understanding of how you get a cold or how you catch germs, not washing your hands, not using a tissue to clean your nose, touching doorknobs that are frequently used, not cleaning off your cell phone, letting other people borrow it, that sort of thing. And there is a table 1.1 in this first module that goes into a little deeper depth. In terms of hospitalization, some of the contributing factors to stress are length of stay and isolation. The longer a child stays in the hospital, the more removed they are from their normal daily routine. And when isolation is required because of a communicable disease or they have a fragile immune system, they cannot be around other people's germs, that sort of thing, that can contribute to stress. Children typically are not permitted to refuse treatments, so this can be very stressful for children. Basically, a lot of their independence and choice is removed when they come into the hospital. Unfamiliar surroundings, being in the hospital for the first time, being away from home, being away from familiarity of family and friends and pets and so forth. Fear of the unknown is very stressful. And this is really where the role of the child life specialist comes into play. We have a duty to explain to children what is going to happen, what is in store for them in terms of a medical encounter. And by giving them information and being honest and open with them and telling them when things may be a little bit uncomfortable or difficult to hold still, that helps to build rapport, a bond, and honesty. We also know that developmental stages from 7 months to 4 years of age are the most difficult time for children to be hospitalized because of the fact that they feel very vulnerable in that first year of life. From 7 months on, they are there is a milestone of separation anxiety, stranger anxiety, and then later on, 2, 3, and 4 years of age, they are they're great pretenders. They make believe is huge, fantasy thinking is huge. So what they don't understand about what is happening, they make believe, conjure up something that is usually 10 times worse than reality. And then when dignity is threatened, when children have to participate in medical procedures and they're not able to wear undergarments, pants, things like that, they can feel like their dignity is threatened. Some child variables are their developmental stage, which correlates with their response to illness. And then what is called threat appraisal, when they are fearful of who's going to give them a shot, they're looking at every nurse that walks through the room to see if she has a syringe. That threat appraisal is very real, and it promotes a negative experience of hospitalization. There are gender differences as well. It's well documented that in research that boys tend to be more physically aggressive when they feel vulnerable, where little girls tend to ask questions. They're much more introverted and they they're more communicative, less aggressive. Temperament plays into this. There's easy temperament, active temperament, slow to warm. This all plays into rapport building and developing a comfort level with caregivers in the hospital. Any previous healthcare experiences will also flavor their perception of what is going to happen and what's going on in the hospital. Some families come into the hospital with the preconceived notion that you're only in the hospital when you're so sick, like Aunt Susie or whatever that went into the hospital and never came out. She died in the hospital. So there are preconceived notions about healthcare, and that will flavor a previous healthcare experience as well. Coping styles. Every child has healthy coping styles, and they do not differ when a child is hospitalized, but they are intensified. And family response to healthcare experiences, like I mentioned, their perception of when you're hospitalized, you must be really sick. And then their support. Are they there at the bedside on a regular basis, or are they not able to be at the bedside with other children in the home that need to be cared for, transportation issues, work schedules, and so on. And then illness variables, which are nicely detailed in Table 1.2, which is also listed in this module. So family composition. Whether a child comes from a single parent home, two parents in the home, two moms, two dads, two grandparents who are parenting the child, or they're children of adoption, or they are foster children. So the family composition is huge for support, as well as siblings, how these children relate to their brothers and sisters. And when children are in the hospital, we exercise a whole child approach. So if the siblings come to visit, then we explain things to the brothers and sisters of what's going on with Johnny or Susie, their sibling in the hospital. So they don't feel pushed out of the picture, and they understand that it's not catchy. It wasn't anything that they said or did or caused their brother or sister to be in the hospital. There are cultural influences as well, family values and their primary language. When families are under stress, they resort to the primary language. And so then we have to provide um, uh, uh, whatever you call it, interpreters, to make sure that families receive information in the language they're most comfortable hearing. There are also parental beliefs and practices that can influence a child's hospitalization. And then other family factors or stressors, financial stressors. If a parent has health insurance and they must continue to work because they don't want to lose their health insurance, then they're not at the bedside. So there are both financial and social resource stressors. Who is the support system for that child, and how can they be more present in the hospitalization? So some of the activity guidelines, when we select an appropriate activity for children, we determine their age and developmental level, because that's pretty key as to what they can handle. And then usually we will back up the skill level to an earlier stage of development, because we want children to feel some success, and then we'll challenge them moving that activity level forward. So we assess the child's temperament and coping style. We review the child's behavior towards stress, and again, it's very detailed in Table 1.3. We consider the child's energy level and attention span. When children are not 100%, when they are not feeling well, when they have had a major surgery, then they are not going to be at 100% energy level. And the rule of thumb used to be that attention span is a child's age plus 1 minute. So if you have a child who's 5, they're going to, on a good day, they're going to attend for about 6 minutes, and then their eyes will wander, and um, you may lose them. So we have to gear activities to capture most of the child's attention, and then know when to redirect them to another activity. We want to determine whether we're going to offer a group or individual activity for a child. So some guidelines for working with children. We want to develop a really solid communication with a child, which means that we're going to ask them questions about what their interests are. We want to get to know them. Do they have a pet? What's their favorite color? Things like that. It helps to develop rapport. And this is really helpful when we are trying to bridge that gap and get our point across to a child that we are a safe person. We don't do any harm to a child. We don't carry syringes or poke or prod or anything like that. So we are a safe person for them to be with. Then there's something called the campfire effect, and there is a question on the midterm about that. So it is a result of a shared activity as a focal point of interaction. And I think this can be best described as when a child is at an activity table with other children, they are focused and concentrating on completing the activity. And then if the facilitator asks a question or shares a prompt like, oh, is this your first hospitalization? Because they are not being singled out, they can freely interact and say, nope, not my first hospitalization, been there, done that, this is my second time or whatever. And then other children kind of chime in. That is considered the campfire effect. So some facilitator guidelines are that we define limits. We're going to spend about 15 minutes on an activity, and then we're going to play a game. We want to define limits for behavior and when we need to redirect. We offer choices whenever possible. We reflect on feelings. If a child plays a game, a group game like bingo or something like that, we assign roles like who wants to be the bingo caller, who wants to manage the little round things that you put on your bingo card. Some of our bingo cards are laminated, and so we can use dry erase markers. Who wants to be in charge of the markers, that sort of thing. That's partly to offer choices and also to say, and who feels like they want more responsibility? Who wants to manage the dry erase markers? Who wants to manage handing out the bingo cards? Who wants to be the bingo caller? That sort of thing. So we reflect on feelings and we make sure that everyone is heard. We want to introduce any special activity considerations. If it's too difficult to hold a pair of scissors, we can provide assistance. If we have one package of markers, then we're going to be sharing, and then we have to help children troubleshoot and say, well, if someone's using the purple marker, then maybe you can use the red one and then you can trade, or put time limits on that sort of thing. We thank children for activity completion, and we always ask them if they want to share their completed activity and say something about it. This is a way to celebrate accomplishments, and it's a way to affirm to the child that they completed the activity, it's a job well done, and they're being praised for that. Some additional activity considerations for children with special diagnoses. In other words, emotional behavioral disorders. Some children are hyperactive. It's documented on their medical chart. Some children are just noticeably we observe them to be hyperactive, and they are not able to sit still for very long or kind of move around the playroom from one activity to another. We also have children who display aggressive behaviors or self-injurious behaviors. So we would restrict them from color pencils that have a sharpened point or use of scissors without supervision. Some children have mood disorders, and they withdraw from group interaction or social interaction. Some children are they display immature behavior or have learning difficulties. So we need to be on top of this and make sure that everyone has successes in an activity room and with activities so that they feel validated. Illnesses that further stress, or illness that can further stress children because of, it can be physically taxing. It can be, they can be fatigued. They cannot feel themselves. They can feel queasy from medications. So we want to provide lots of choices. We want to help children proactively manage behavior meltdowns, explain expected behavior. In other words, set limits, like we have about 5 more minutes before we're going to clean up our activity. If you do not finish, you can take materials back to your room and finish your activity there. And then we all have another 1-minute warning to help children make transitions from playroom is closing. It will soon be lunchtime, and we're going back to our rooms, and I'll help you turn on the television for our closed circuit television show, things like that. Also paying attention to warning signs and being aware and 2 steps ahead of children who have documented emotional and behavioral disorders. We want to make sure that they can keep their composure and dignity in a playroom setting with other children so that they don't get embarrassed if they become overwhelmed, overstimulated, or overchallenged. So if those things occur when children have a meltdown, then we just say, okay, well, that didn't quite work out the way that maybe we thought. So we'll start fresh in the afternoon play session so that there is a new beginning. It's not like elementary school where it's like, a signal light where if everybody comes into the room, they stay on green until you have a warning. Then you have to go and switch your card to yellow, and then another warning switches you to red, and there's no going back. And so this can be very damaging for children because they cannot they can't recoup that green light. So it just becomes a very demeaning and negative. Children with autism and Asperger's syndrome, and again, these are statistics are from 2009, so they're a good bit old, and the statistics have actually increased. It sounds weird to say that, but it's not 1 in 80 children who are on the spectrum. It's more like 1 in 40 to 60 children are on the spectrum. In the US, 1 in 110, no, it's like 1 in 80 are on the spectrum. Autism is a developmental brain disorder that affects a person's ability to communicate, socially interact, and respond appropriately to the environment. It is an issue with a brain protein, and that protein is what destroys the synaptic charge that a signal, it's like you need to pay attention, and so then the signal doesn't go through, and then they they're not paying attention, that sort of thing. So there are a variety of treatments for that. There's a GFCF diet, which is casein-free, gluten-free, which means no milk products, no wheat. Wheat is gluten, and casein is the milk protein. So there are also certain dyes in our food, like the red coloring and red licorice can accelerate behavior, can make a child even more hyperactive. A lot of sugar can do that as well. And there are medications, and there's biofeedback and a lot of other treatments for autism spectrum disorder diagnoses that may be an alternative to medications. Sometimes called pervasive developmental disorder, or PDD, which is a new assigned title in the DSM-5, which is the Diagnostic and Symptom manual. It is used by social workers and clinicians, psychologists, psychiatrists, and sometimes child life. Because the codes are in there for different developmental disorders. Children with higher functioning levels of like IQs are typically Asperger's syndrome kiddos. They are on the spectrum. They can have social interaction issues and respond differently to the environment, may have some communication issues, may not give you eye contact when you speak to them, but they tend to have a higher IQ, and sometimes their symptoms are camouflaged. So guidelines for working with children on the spectrum: we want to be aware of the different stimuli in the environment, lighting, sounds, crowds, touch, and these are all things that are very much apparent in healthcare. Lights are on all the time. The temperatures are usually a little bit colder in a hospital. Bacteria grows in warm weather, so it's typically pretty cold. There are always older overhead pages. There are people moving to and from children's rooms, the cafeteria and the hallways and so forth. And then when a child is on the spectrum, they may not handle being touched. They may become hypersensitive to touch. And so we have what is called the Blue Starfish program, where we place a blue starfish on the door of a patient's room just as a clinician signal that this is a child on the spectrum. So we need to kind of pull back a little bit with our overly friendly rapport building. We want to make sure that we offer choices, present with simple instructions, 1, 2, 3 steps. Provide clear, concise, concrete instructions. Sometimes we use simple images to illustrate steps on picture cards, and it'll be 1, 2, 3. These are the steps. And then sometimes we can validate a child's understanding by saying, we'll move the cards out of order and have the child put the cards back into order. We provide transition cues from one thing to the next to help with that transition. We offer support for social interactions and help kind of bridge, getting to know their peers in an activity room, or say, hey, Johnny, you're 7 years old, so is so-and-so. Isn't that something? Just to kind of get them to notice each other and maybe help them develop a friendship. We help children develop a cue for avoiding their own meltdowns, whether it's putting their hand on their head, or touching their chin, or putting their hand in the air, or putting their head down on the activity table. They are giving us a signal, and these are usually prearranged signals or cues that they're having trouble staying focused, they're overwhelmed, they're challenged, and we have to be mindful of that. Children with brain injuries, we gauge whether a traumatic brain injury child can follow simple 1 and 2 step directions. Sometimes it is as simple as blinking their eyes for yes and twice for no. We provide repetition and consistency. We will introduce ourselves every time we enter the room. Like, hi, do you remember me? My name is Debbie. And sometimes these kiddos will put a little notepad on a lanyard and they'll wear it around their neck so that they can write things, or we can help them write things in their notebook to help them remember from one day to the next. We want to demonstrate new tasks very carefully, very slowly, and validate learning after every step. What happens when you have a traumatic brain injury? The brain is actually like a large soft muscle. And when you know that when you bump a muscle, you can get a bruise. It's the muscle bleeds and it bruises. That bleeding is what you see under the skin. It's the red and the purple. That's blood and fluids under the skin, because that muscle was traumatized. And so when you have, there's nothing hard protecting the muscle. So that's when you see the bruise. But with your brain, you've got a skull, a hard skull bone that is protecting the brain. So in a traumatic brain injury, like forcefully, like a child is hit in the head, say by a baseball, or they're in a car accident and their body is thrown and their head hits the pavement, something like that. The brain as a muscle hits the side of the skull and it starts to bleed. It's bruised. And you don't want to have a lot of bleeding and swelling, excuse me, in the brain, excuse me, because then the brain has nowhere to go when it's swelling. So it pinches off simple pathways for speaking, for movement, for learning simple commands. And you have to relearn all of that, and we have to wait until the swelling goes down, and then see what the child can regain, or we help them regain those skills with physical therapy, occupational therapy, speech therapy, and on and on. So that repetition and consistency are very, very important. We want to avoid figurative language, things like saying they're going to bring a stretcher. Figurative language is, if you can only comprehend a linear definition of the word stretcher, maybe a child is thinking that someone's going to stretch them and pull on their arms and legs. So we would say someone will bring a bed with wheels. It's also called a gurney. And this will be your ride to the operating room or to a procedure or a treatment, that sort of thing. We want to reinforce lengthening periods of attention to tasks and applaud them for, wow, you were able to pay attention for 3 minutes today. I'm so proud of you. Might be listening to music and not starting to nod off or something like that. So we want to probe skill acquisition very frequently and say, so tell me, what have you learned today? And that's amazing. I'm so proud of you. And it can be very simple tasks, but they are going to build upon that skill acquisition on a daily basis. That's the consistency and the repetition. We want to teach strategies for improving their memory. Again, that's why we would put a little notebook on a lanyard around their neck so they can write things down, maybe write down my name so I don't have to introduce it. Maybe the next day, introduce myself on every single day. Maybe after several weeks, I would say, do you remember my name? I'm not going to tell you. You can look in your notebook. And they might have to look in their notebook to see that they wrote Debbie, okay? We want to be prepared for traumatic brain injury patients getting very fatigued quickly and having a reduced stamina. These kiddos are in comprehensive therapies, OTPT and speech on a regular basis, like several hours a day. And that really can wear them down because we must show that progress to keep them in a rehab facility. So we want to make sure that we are, packing their schedule with as much therapy as possible and a little bit of downtime. So we are usually very prepared that these kiddos are going to be pretty fatigued when they come to the activity room or we see them at their bedside. We keep the environment safe and distraction free for them, trying to eliminate as many noxious stimulation as possible, maybe keeping the lights off in their room to make it a little bit more comfortable and dimming the lights, closing the curtains so that the bright sunlight doesn't react with their eyes and that sort of thing. When we work with abused and maltreated and neglected children, we want them to always feel very emotionally safe. They will usually regard us as a safe person. And because we don't do any medical procedures, they tend to disclose information to us. So, we try to be very approachable, very patient, very supportive listeners. We want to communicate a protective presence and show them that we understand them and believe what they say. And generally, any child under the age of 18 is not going to make up wrongdoings. So 99% of the time it's very believable. They wouldn't disclose something horrific if it didn't happen. And we let children know that they can talk openly to us. When they do disclose information, we would document what they disclosed. We would have a conversation with other team members, like the social work team and the psych team, to make sure that everybody's on the same page of what happened in an activity session. We want to affirm that children can, in fact, confide in us and assure them that they are not to blame for anything. Anyone under 18, when there is a wrongdoing done to them, they are never to blame. It is the perpetrator who committed the wrongdoing to the child, and then whomever their caretaker is would be informed. We want to stay calm because children can really disclose some very amazing information. And we have to remain composed and we have to remain calm and not rattled by any of the information. Children can read body language pretty easily. And if you open your eyes really wide and say, oh my goodness, that sort of thing, that can startle a child and they may not want to further disclose. So we provide positive feedback. We say, you are very brave to tell me these things, but you are safe here in the hospital. We are going to protect you. We reinforce that playrooms are a safe haven, that nothing medical can go on in the playroom, and that they are safe in the hospital. We help children learn conflict resolution skills through role modeling and by telling them that when an adult does something harmful to them, it is very wrong and they should know better. And so a child must learn to say no, and you stop, and stay back or stay away, and to find an adult that they can confide in and explain what happened. So we are fostering also peer relationships through all of this when a child is in an activity room by kind of, again, bridging that social interaction gap with introducing them to other children. As far as disaster victims go, the American Academy of Pediatrics defines disaster as an event that involves injury or loss of life and destruction of property. Gender is a factor in response to disaster. As I mentioned before, boys tend to display violent and aggressive behaviors and display externalizing symptoms and antisocial behavior. Girls tend to require a longer recovery period and display internalizing symptoms such as anxiety and mood disturbances, which are more expressive than boys with their emotion. And then there is a detailed table 1.5 that goes further into depth about disaster victim responses. Children respond to disasters, though, in two distinct stages. The first stage is very emotional, emotive, through fear, disbelief, denial, grief, and relief if a loved one is unharmed. This could be a car accident, it could be a fire, it could be a flood, it could be a tornado, it could, a variety of things. The second stage are developmental regressions or manifestations of the emotional distress. So once a child emotes, then it can create internal conflict. Then they show anxiety and sadness and depressive symptoms. We expect patients to regress when they are faced with a crisis, whether it's emotional or physical or what have you. Being in the hospital is considered a crisis situation because this is not their home. This is not their normal routine. And for many patients, it is a first visit. And it can be a very sterile environment. It is very different from home. They are away or separated from everybody that's supportive or and loved and that sort of thing. And so we expect patients to regress. And the thinking is that when you are faced with a crisis, you take 2 steps back into an earlier stage of development. 1 second. Oh, sorry, it stopped. To an earlier stage of development when you have mastered all of the milestones, and then you can kind of make sense of what's going on, the stress, the crisis, what have you, and then you move slowly through and back to the developmental continuum. Okay. So some tips for working with disaster victims. We indicate that we are available to listen. We use a calm tone of voice. In other words, we don't want to be all hopped up on caffeine and go bouncing into a patient's room like Tigger. And so we have to make sure that our demeanor is identical to that of the room. We get on the child's eye level to speak with them. We follow the child's lead. We don't prompt them to answer questions. We would just say, hey, we introduce ourselves and say, I can bring you some toys, something like that, or some activities. Support the child's emotions and fears, and that goes hand in hand with developing that rapport. And we help children identify their feelings on what was really scary, and those are some very big feelings that they're feeling, and it's okay to have big feelings. And we talk about it and consider group projects, because children then kind of let their guard down when they're concentrating on a group project, and then they kind of effervesce up and talk about things anyways. We design a range of expressive activities so that we always have something else in our back pocket, so to speak, if one activity is not well received. We reassure children that there is no one right way to express feelings. Some people cry, some people yell, some people withdraw and get really quiet. There's no correct way to express big feelings. And we allow children to share their finished activity. Children, however, with physical restrictions, there are some tips to working successfully with them. We create an accepting environment, inviting children into activity rooms of, whether they're on crutches, in a wheelchair, what have you, on a gurney. We make sure and make room and welcome everyone into the activity room. We avoid assuming that a child cannot do something. We let a child do as much as they can. We'll check with them to see if they're having any challenges, and then we move forward with assistance. We can adapt materials and equipment as needed. Sometimes we've had to tape pencils, markers, crayons to their hand so that they can move the material, the writing materials around on the paper. Sometimes we have to hold the paper for them to use the scissors, or vice versa. They hold the paper and we use the scissors, and they tell us where to cut. We consider the use of adaptive equipment, which helps them to still find mastery over activities and skills than not, dealing with the activity at all. We find out what a child's strengths are and we capitalize on them. We keep our expectations high. We don't offer activities that are 4 or 5 levels below their current level. We do want to back up a little bit our expectation, not our expectation, but the difficulty of an activity, because we want to make sure that they feel successful, and then we move it forward to make it challenging. We let a child do as much as possible. When a child cannot play or create something, then we sometimes become an extension of that child's ability to complete the activity. They are directing us with their verbal skills of what color they want for a picture, or for the sky or the grass or the flower or what have you. And we become their mobility to create that. And then because they directed the activity, then they feel accomplished and want to hang up the activity or display the activity in their room. Some additional considerations: when children cannot play, we play for them. A children's age and developmental level are always taken into account when we are introducing an activity. The types of materials: there are some materials that are easier to work with than others. Construction paper is a little heavier than tissue paper, and when some children have restricted mobility and they're not able to do a pincer grip, which is putting your first finger and thumb together, then it would be difficult to hold tissue paper. So we have to make sure that we use a variety of materials to match all developmental and challenge levels. And the same with toys. We would have a variety of toys that require a variety of techniques to manipulate those toys. And the same with activities. And then the children's condition, the child's condition is important to remember. If you've got a child with an IV and say their dominant hand, then they're going to be very compromised in doing an activity if they have to use writing tools with their left hand or scissors with their left hand. So we want to be aware of the child's condition and any sort of challenges. Separation, there are 3 stages of separation anxiety, and there's a question on the midterm about this. It was first created by Bowlby and Robertson in 1958, and then re-authored by Bowlby in 1960, and it is still a prominent theory today called separation anxiety. The first stage is protest. As an example, if you think about a young child, say under the age of 2, and they're in the hospital and the parent needs to go home, and the child stands up in the crib and they grab the bars and they're shaking the bars and they're crying and screaming and they don't want their parent to leave. They are in protest, okay? If a couple of days go by, or several days or a week, and the parent has not been able to come back and visit for whatever reason, the child may sink into a despair state, and they will rebond with their immediate caregivers. They become more attached to their primary nurse, and then when the parent does come back, and these are, extreme cases, but when the parent does come back to the child basically will reach for the nurse as a way of saying, this is my new friend. Yeah, this is who I care about. So that's the detachment. They kind of leave their primary caregiver behind and they have reattached with a new bond from their primary nurse. This is an interesting slide, and there is a question on the midterm about this. Homesickness is an actual physiological effect. It is the distress and functional impairment caused by an actual or anticipated separation from home and attachment objects, such as parents. So a child who is homesick can have physiological characteristics. It can manifest itself with the child will run a temperature, may have a stomach ache, may have a headache. It is the most prevalent type of distress experienced by hospitalized children, with 88% of hospitalized children reporting homesick feelings. So it is a very real condition, situation that can arise from being separated from loved ones. So the activity goal this week, there are 3 listed here, but I don't want you to pay attention to those 3. I want you to only focus on the All About Me poster, okay? The All About Me poster is what is assigned for this week. This is directly from your textbook, but this is not the information I want you to add to the write-up. And let me show you what an All About Me poster would look like. Just 1 second here. Reach into my bag. So this is an All About Me poster that I made. And I do not want you to use a computer to make your All About Me poster. And you do need to create this yourself, not with people you share your life with, not children that you see in a classroom, not nieces and nephews. Just take a piece of paper and I want you to put shapes and words. And I have cut out some things from paper and I wrote sunshine because I love the sun. This is my child life family, and this is, I cut a picture out of a brochure. And then I love the color purple. And then my favorite food is spaghetti. Okay, I'm Italian. So if you are not an artist, then cut out pictures from a magazine, or write the words in different colors or something. But an All About Me poster is a way for you to communicate to strangers what it is about you that you want them to know. And so in the hospital setting, we use something similar. Let me see if I can find it. Um, and we fill these out with every patient. Now, this is something our marketing department made. I do not want you to make anything on the computer like this, but it says, "Who am I?" And this is a way for even young children to, and we'll fill this out with a parent who knows the child best. I like to be called, like if their name is Deborah, like me, I like to be called Debbie, Debi. I am, we'll say I'm 6 years old. So I'm not telling you how old I am. My favorite color is purple. My favorite food is spaghetti. My favorite animal is goldfish. I don't know, I guess, or cats, kittens. My favorite sport is bicycling. When I grow up, I want to be a FBI agent. My best friend is, her name is Suzanne. My favorite TV show is Saturday Night Live. When I'm scared, I freeze. I freeze. So that is something that we created on the computer, but I don't want you to create something on the computer. Okay. I want you to create something with just materials you have around your home, or wherever you live. I don't want you to have to go out and buy anything. If all you have are some markers or colored pencils or crayons, great, and a piece of paper, that's what you need to do. You are not going to be graded on your artistic ability, okay? But you do need to add 7 pieces of information after you create your activity. You take your phone and you take a cell phone, a photo of it, okay? And then you're going to upload this picture to a Word document. And you will have the title at the top in bold, All About Me poster. You'll have the picture, and that's the second piece of information. The third piece of information is the activity objective. You're going to write the activity objective subheading in bold, and then you're going to align that description with the chapter. Okay, the chapter theme is separation and stranger anxiety. So you will include that in your therapeutic goal. The All About Me poster helps to build rapport with hospital caregivers to bridge or foster a sense of connectedness, to bridge the gap of separation and stranger anxiety. Okay, something like that. Okay. Then you're going to put what you feel the age for that project is best suited for. There's no bad answer for that. You're going to then have materials in bold, and then you can list them out if you want: paper, markers, crayons, glue stick, scissors, whatever. Then you're going to have a safety precaution or special consideration, a heading in bold, and you'll write, when using scissors with young children, be mindful that their scissors can be sharp, unless you have rounded edge scissors. Glue sticks sometimes and markers can get put into the mouth if they're a young child. And then lastly, you're going to have subjective commentary in bold, and then you're going to write how you felt while you were doing your project. Okay. No one ever asked me about what things that I like. It was really great to really think about it. At first, I didn't know how to begin, and then I was listening to music, and it all just kind of came out. And I'm really happy with how my All About Me poster turned out. So that's what is in an activity write-up. Okay, not a whole lot of this other superfluous information, not about adult-child ratio or required time or the process. No, I don't want you to put all of that extra stuff in. Okay, but each and every one of these activities that you are assigned come from the book. Okay. So that's what I have for you, and hopefully you can hit the ground running with these activities. Again, they are all made by you. I don't want you to Google something and take a picture off the internet or whatever. That's not appropriate. Okay. I don't want a child to create these things. I want you to create these things. Okay. All right, so that's what I have, and see if I can click out.